In my 15 years here at St. Alexius, I haven't seen a program have a greater impact this quickly ever.
It's not that we didn't have sepsis protocols when we began this work. We did have sepsis protocols. I think what was key here is when you begin to measure how well you're following those protocols and actually implementing the protocol rather than it just being a piece of paper.
There was inconsistency on the nursing piece, on the physician piece. So we had to look at how to get everyone on the same page. So it had to start off with education, and then we had to look at how do we standardize. And that was the biggest piece, is that we had to have sepsis at the forefront.
We also provided nursing education house-wide. We had it as part of our health fairs as information, what to look for. We posted posters throughout the whole hospital and in the doctor's lounge. What is the first steps to do? You know, what identifies a patient as a severe sepsis or shock?
In 2010, in February, we came up with doing it as an alert, making sepsis a real priority to really get mainly the detection and identification of the patients, a little more center for our staff, and then when an alert was called, to have a process where we wouldn't have any fallouts with lab and the top 4 in our bundle.
Certainly there was significant communication between the nursing staff and the physicians to coordinate not only obtaining the blood cultures, the lactic acid, but making sure that the antibiotics were given in a timely fashion and making sure there was adequate fluid resuscitation, and thereby decreasing our mortality from what was once over 20% to now close to 10%.
If you don't have physician support, you're not going to get anywhere. So it's definitely the most valuable asset to have is part of your ICU team. Your doctors have to be on board with the protocol, or else you're not going to go anywhere.
Our role as the intensivists was to be the first responders. If patients met enough criteria, the alert was called and we responded to wherever the call came from, whether it was on the floor or in the ER itself.
The biggest thing I would say is standardization. Having the same process for the patients that come in each time will definitely help with identifying fallouts. You know you're not going to miss patients with the standardized process in place. At 103.9 fever, wasn't coming down with any antipyretics. I was one of those unknown sources of sepsis. My fever wasn't coming down, just kind of felt that general achy conditions. The physician, who's wonderful, took care of me, followed the sepsis protocol, ended up getting admitted to the floor. And about an hour after I made it to the floor, they called a rapid response because my blood pressure was barely above 70. And I was a diagnosed sepsis patient. We have these protocols, we cast this wide net, and some of the questions are, well, are you over-treating sepsis? But how can you argue the decrease in the mortality rate that we're having?
Good care is cost-effective care. And that by attending to the patient in a timely fashion for any number of diseases, sepsis being one of them, helps improve outcomes and optimizes the opportunity for the patient to be returned to their maximum level of health. And that in turn is cost-effective medicine.
In less than 2 years, we've driven the mortality rates down 50 to 70%. We've got a program that's saving resources in a challenging healthcare environment. We've got a program that is virtually seamless in its collaboration of the ER and ICU doctors. It's probably one of the things that I'm most proud of in my time here at St. Alexius.